Well, here we are once again for our 2024 summit, and we're about to begin a discussion on prostate cancer. And we want to thank our sponsors, Janssen, Retrophin, and Myovant. So African-American men are 50% more likely to develop prostate cancer in their lifetime and twice as likely to die from the disease. 1 in 8 African-American men will have prostate cancer in their lifetime. In order to provide us with a little more information on how to deal with these issues is Dr. James K. Bennett, who's received his medical degree from Duke University in 1979, and then attended Emory University, where he completed an internship in surgery and a residency in urology. His enthusiasm continues today through the establishment of a urology practice providing quality health care. Dr. James K. Bennett, thank you for joining us today, and we look forward to hearing more about what you have to say about prostate cancer. Thank you so much.
Well, good morning, everyone, and I apologize. I have some technical issues with this computer, and so I can't bring up the video presentation, but the message is going to be the same. I've devoted my entire professional career toward understanding prostate cancer and also addressing the disparity within our community. And so this presentation will go over some of the myths associated with prostate cancer, and also some of the things that we can do as a community to, I'm trying to mute my phone, as a community to address this devastating disease in our community. As was stated earlier, more than 200,000 new cases of prostate cancer will be diagnosed each year. And the vast majority of those patients will be in African Americans or people of African descent. Unfortunately, there's been a lot of misinformation about the impact that prostate cancer has had on our community, but hopefully by the end of this presentation today, we can dispel many of those misconceptions and myths. About 30,000 men will die from prostate cancer. As it is with the incidence of prostate cancer, the mortality in prostate cancer is also increased in African-American men. Generally speaking, 50% more African-American men will die from prostate cancer. And usually these men are usually present with a higher stage of cancer as well as at an earlier age. So you can see the impact of this disease in our community. Unfortunately, most African-American men don't want to go to the doctor, and that's what leads to such a high mortality of this disease in our community. You see, a man would rather take care of his car and get the oil change versus taking care of himself and doing that routine maintenance as he would do for his car. So the important thing for this discussion is for men to be an engaged participant in their health care. And by engaging, then they are able to make sure that they are not afflicted with this disease, but hopefully they will take the same message and vigor that they have assumed in their lives back to their homes and back to their community. And as we get into this discussion, you'll see why that is so important. Now, before we get into really some of the more detailed discussion of symptoms and diagnosis, the one thing I want to point out at the beginning of this, because this is going to be a very important discussion point at the end of this presentation, and that is this very simple point. You see, most of us think that we are healthy one day, and then the next day we wake up with a disease, and in this case, it's prostate cancer. I've had so many men that come in and I diagnose them with prostate cancer, and the first words out of their mouth is, "Doc, I started eating right about 3 years ago. why do I have this now? See, I've dropped weight, I've done all this stuff. And my response to them is this, is that unfortunately, prostate cancer is one of those diseases, as most diseases, that manifest themselves and become evident over a period of years. I will say to you is that 1 in 3 men in their late teens and early 20s already have cancerous changes in the prostate. And so it's those cancerous changes 20 to 30 years later that leads to invasive prostate cancer. So you see, you have a window of 20 to 30 years before the cancer really shows its face. So during that period of time, it is important that you address that cancerous change that may have occurred in your prostate by doing the right thing. And we're going to talk about those right things later on in this presentation. The other aspect that men always bring up to me is this, is they always say to me, is Dr. Bennett, you know, I have no problems urinating. I get up one time at night or sometimes not at all. I still urinate very well. I pee like a racehorse. That's one of their favorite sayings they like to say to me. Unfortunately, with prostate cancer, and particularly early prostate cancer, there may not be any symptoms at all. And because there are no symptoms, they wait until symptoms develop sometime. And by the time symptoms develop as a consequence of prostate cancer, usually by then, if you have symptoms, and if those symptoms are due to prostate cancer, you've already waited too late. So the key thing is to make sure you go in for routine maintenance. Now, the symptoms that may be associated with an enlarged prostate, not specific for prostate cancer, or things like a decreased force of stream, hesitancy, meaning when you go to the restroom and a guy beside you in an adjacent urinal has come and gone and you're still standing there waiting for someone to turn the water on, that's called hesitancy. And when you finish and then you think you're done and you walk away and you look down in your trousers, you have a trail of urine down your either leg. That's called dribbling. Frequency of urination, urgency. I've had numerous men say to me, Dr. Bennett, time I think about there's a bathroom or I drive up to my house, I have to bust the door down to get into the house. That's called urgency. And in many cases, if you don't address that urgency, it could lead to leakage of urine, and that is called urinary, and that's called urge incontinence. So all of these symptoms may be a sign of prostate cancer, but usually most of these type symptoms are due to benign enlargement of the prostate. I'm going to repeat it again. Early prostate cancer generally is not associated with any symptoms at all. So the key thing is, again, is to come in for routine maintenance. Now, when you come into a physician, there are two main things that the physician will more than likely will order. One would be on your physical exam, he'll do what we call a digital rectal exam. And we're not talking about a computer program. We're talking about a finger that's inserted into the rectum to feel the back surface of the prostate and to make sure that that back surface of the prostate doesn't have any hard areas, or we call them nodule, or if one lobe is bigger than the other, we call that asymmetry. So any part of that exam that's abnormal is, and any part of that exam that's not normal, we consider it as normal. And so that's why the rectal exam is so important. Now, a lot of men say, well, Doc, with that test we have out now, that blood test, I think it's called a PSA. Well, yes, the PSA, prostatic specific antigen, is a blood test that is used to help the physician be aware of whether there's a suspicion of prostate cancer. And typically the laboratory value will give you an upper limit of normal of 4. The PSA is not a very good specific test for prostate cancer. So as with any test, there's an art of how to use that test. What we have learned over the years is that if a man has a family history of prostate cancer, or if he is of African descent, so it doesn't mean whether you are from Jamaica or Canada or the East Coast of or the West Coast of Africa, your incidence is probably going to be very similar. So it's really the African ethnicity that makes you at higher risk for a variety of reasons. And we'll talk about some of those reasons. So if you are in a high-risk group, family history or men of African descent, what we have found that if you have a life expectancy of greater than 10 years, probably the cutoff would more than likely be best served if you use a cutoff of 2.5 rather than 4. The other art of using a PSA is the rate of change of the PSA from 1 year to the next. So if your PSA changes generally more than 0.35 from 1 year to the next, that should also indicate a worrisome change in your blood test. And that should at least prompt a discussion with your primary care physician and or your urologist, because that may be something that needs to be investigated even further. Now, the best way we investigate whether you have prostate cancer is by doing a prostate biopsy. And the biopsy is simply is that we take a little small needle and using an ultrasound, we take samples from either side of the prostate, and those samples are sent to the laboratory to check for evidence of prostate cancer. And once that information comes back, it generally it prompts the urologist and the family and the patient to have a detailed discussion about the substance of what was found on the biopsy. Now, one of the things I will say to men of African descent is that how we talked about earlier about when you do the rectal exam and you feel for hard areas in the prostate, or if you feel one side being larger than the other. In African-American men, it is not uncommon for you to have a normal rectal exam and not feel anything. And the other intriguing thing, or not intriguing, but interesting finding sometimes, is that the PSA may not always indicate whether there's worrisome areas of prostate cancer in your body. The reason for that is when we're doing a rectal exam, we're feeling what we call the posterior surface of the prostate. And that's where, for Caucasian men, many of their cancers are found. In African-American men, many of our cancers are found anteriorly, meaning that part where you cannot feel with your finger in the rectum. And those are anterior type tumors that are present in the prostate. And unfortunately, many of these anterior line tumors are also very, very aggressive, much more aggressive than many of the posterior tumors that occur in the prostate. So it is so important that if you are to undergo a biopsy of the prostate, that the urologist is aware of this particular finding, particularly in men of African descent. Now, one of the other tools that we have now started to incorporate in our toolbox is the use of an MRI. Now, what an MRI is just an X-ray, and it actually looks at specific areas in the prostate based upon what we call the PIRAD system. And that generally is a scoring system that the radiologist uses to let the urologist and the patient know whether there's areas in the prostate that fits different aspects of this PIRAD system. Generally, the PIRAD numbers go from 1 to 5. Anything less than 3 is not worrisome, but 3, 4, and 5, and with 5 being the most worrisome areas, or areas that we generally want to make sure we focus on when we get ready to do a biopsy. And many of those biopsies, again, if you have a abnormal MRI and you have PIRADS 4, 5 score, then that means then that those areas need to be targeted. And also, unfortunately, many of those cancers are much more aggressive than your run-of-the-mill Gleason 6 or less type cancers. So the MRI is a very excellent tool that can assist the urologist in determining where to biopsy. Now, the key thing that patients need to understand is that the MRI doesn't tell you whether you have cancer or not. So even if you got an abnormal MRI, if you have a normal MRI, still doesn't mean that you don't have prostate cancer. But if your MRI is abnormal, then there is I would say a greater than average chance that once you have a biopsy, that there will be cancer that's found, and generally those cancers tend to be much more aggressive. Now, you heard me mention a Gleason score, and what a Gleason score is the behavior of the cancers that the pathologist, when he looks under the microscope, he sees different patterns these cancers make. It's almost like looking at 5 different kind of flowers. You have a rose, which looks different from a daffodil, which looks different from a tulip. So basically what the pathologist does is that he looks under the microscope, and so one of the first questions he asks is, what do I see the most of? Oh, I see this pattern. Let's arbitrarily say it's a pattern 3. And then he'll say, then what do I see the next most? Oh, I see the same pattern. And that's where you get the Gleason score 6, or 3 + 3 = 6. Generally speaking, Gleason scores of 6 or less are felt to be in grade group 1. A Gleason score of 3 + 4 is usually in grade group 2. A 4 + 3 Gleason score falls in grade group 3. A Gleason score of 8 generally will fall in grade group 4, and Gleason scores of 9s and 10 fall into the highest grade group, which is generally is a grade group 5. So it's important for you to understand the Gleason scores, because generally speaking, your treatment is generally determined by, to a large extent, of what those Gleason scores are. The other thing the Gleason scores also do is that it helps the urologist and the treating physicians know that if you have a high risk or an intermediate risk prostate cancer or a high risk prostate cancer, that there may be additional diagnostic tests that need to be done. And in my opinion, that's probably beyond the scope of this discussion. The other exciting thing that we are starting to use a lot more, and women have always been aware of this because of the nature of screening for breast cancer, where you look for certain genetic markers like BRCA1 and BRCA2, we're starting to see these same genetic screenings to occur in men, particularly in men who have, say, a non-favorable intermediate risk cancer or a higher high-risk prostate cancer. Generally, we are now looking at checking as to whether some of these mutation abnormalities are present, because what we are finding is that some of the newer drug therapies are tied to whether any of these type markers or mutations are present, and if they are, then if you end up with advanced disease, some of the newer drug therapies are specific for those genetic mutations. So your treating physicians, particularly if you fall in those risk groups, probably should look at screening you and your families for those type of markers. The other thing that will also help, and we'll talk about that when we start talking about treatment, but I can get into some of it now, is that if you have a diagnosis of prostate cancer and you're entertaining what you should do, there are different modalities that can be done on your tissue to tell you whether that your prostate cancer is an aggressive type or not. And one such test is called Polaris, and that test is generally done after a diagnosis is made. It helps guide the physician as to whether a patient is a candidate for observation or active surveillance, or whether he's at risk for advancement of that disease, which may prompt a discussion of more aggressive type of treatment. Now, that's a nice segue into treatment. Unfortunately, and this is something that I deal with all of the time, unfortunately, there's never been a study in the history of urology that has proven that one treatment is better than the other. And because there's never been a treatment to prove that one treatment is better than the other, it would be very inappropriate for any physician, regardless of specialty, to say to a patient, this is the best proven therapy. That is that physician or that provider's bias. It is not science. And so what generally I do is that I educate patients on all of the therapies, and I stress to them that everybody wants to survive. But people, we as physicians sometimes don't pay enough attention to the quality of life. And I believe that both your long-term survival as well as your quality of life are both important. And it's important for physicians to make sure that patients understand their quality of life, because if you take me, I'll take 15 years of quality life over 20, 25 years of miserable life every time. So the two things that negatively impact people's quality of life with treatment of prostate cancer are urinary incontinence, which is loss of control of water, and that means, you know, when you have to wear pads in your underwear, otherwise you will walk around wet or you'll smell like urine. And the other side effect is that of erectile dysfunction. Now, most men, we get caught up on erectile dysfunction. You see, I will argue with you is that erectile dysfunction impacts your quality of life, but not nearly as much as urinary incontinence. I can walk in a room and tell you whether a patient is leaking urine because it's going to smell like urine. But I can't walk in a room and tell you whether a man is not having an erection because that's not an evident thing. So quality of life is really more tied to, in my opinion, when you're treating prostate cancer, to urinary incontinence. And so it's very important that, you know, that you weigh the pros and cons of each of those therapies before you make a final decision. So those treatment options, I'll just briefly mention them. And if anyone has specific questions about these options, by all means, you know, go on the chat line and we'll have some time at the end to address that. But the treatment options are observation, and generally observations are for men that have low risk or favorable intermediate risk prostate cancer. The hormonal therapy, which is another option, is there are two ways we use hormonal therapy. One is for advanced disease, which means cancer that's either in the lymph nodes or cancer that has gone to the bones. The other way we use hormonal therapy, and what hormonal therapy, let me clarify that for the audience, is a way to stop the male testicles from making testosterone. And so we use hormonal therapy for those, for advanced disease, but we also use hormonal therapy as an adjunct for other type therapies, such as radiation therapy and or cryosurgery, which is one of the other options. The radical prostatectomy is certainly one of the more popular approaches to prostate cancer. And again, as I've stated before, there is no proven best way to treat prostate cancer. The one and probably most popular way to do a radical is a robotic radical prostatectomy. Don't be misled. The robotic radical prostatectomy, it is not a panacea, meaning that you can still have the same side effects as you would with a traditional open approach. For that reason, my bias is that toward a radical perineal prostatectomy. But it doesn't matter about the approach, whether it's robotic or whether it's perineal or whether it's retropubic. The outcomes still is tied to the expertise of the surgeon. I always use this example. You can buy a brand new car and you can have a good driver and you can have a bad driver. Obviously, your best outcome is going to be with a good driver versus someone who's sort of careless when they're driving. So the same thing applies to surgery. Radiation therapy is also another treatment option, and there are two forms of radiation therapy: external radiation, and there are a whole host of external radiation, and probably the more popular, which you've heard about recently, is the proton beam, which is still a form of external radiation, and also an internal radiation, and there are two forms of internal radiation. You have the radiation seed implants, and you also have high-dose radiation therapy, which are non-permanent catheters that are placed within the prostate. And then finally, there's an option of cryosurgery, which is freezing the prostate. And it too has some pros and cons, but it also is a reasonable option for a lot of men who are concerned about their urinary control, but also those men that are in their that are older, men in 70s and 80s, and actually some men in the 60s as well may benefit from this. The one neat thing about cryosurgery is that you can do what we call targeted or focal therapy, meaning that if someone has cancer on one side or the other, you can really control the ice to the point where you can eradicate that cancer and not treat the whole prostate cancer. It's very similar to that. It's very similar to doing a lumpectomy in a woman instead of taking the whole breast. And so this is a way of doing focal therapy in men. The other treatment that you'll hear about, I'm not a big believer in it, and that's HIFU, high intensity focused ultrasound. I think it does have a role, but my experience, at least my knowledge and my limited experience, there are some complications associated with it. And before you go down that road, make sure your person who may be proposing to do HIFU has a lot of experience, and you should not be embarrassed about asking that question. So those are the treatment options that you should entertain or that are going to be available to you if you are diagnosed with prostate cancer. Now, what I want to go over and finishing up here is what I tell every patient is that these things that we just talked about in terms of treating prostate cancer are the things that will take care of the acute situation. But your long-term survival is not tied to that. Your long-term survival is actually tied to your immune system. You see, I always when I discuss with the patient about prostate cancer, I remind them that if you go to church and you ask the audience how many you want to go to heaven, and everybody raises their hand, then you ask them how many you want to die, and all the hands go down. Well, the same thing with prostate cancer as it is with most diseases. Everybody wants good health, but no one wants to make the sacrifices for good health. And this sacrifice for prostate cancer is really related to your diet and your physical activity. So in terms of physical activity, you need to achieve and maintain a healthy weight, you need to be physically active, and you need to have a healthy diet. And what is that healthy diet? Well, the healthy diet would include getting rid of the animal fat in your diet. And that means the beef, the pork, the fried foods, the dairy. Why dairy? Dairy has a lot of animal fat in it. And because of that, I would appeal to you is to try dairy alternatives. So what you should do is eat more fruits and nuts and making sure that you use and try to avoid dairy by using plant-based products such as almond or soy. The other very common overlooked item in our diet, and it's definitely present in 70 to 80% of African Americans, is a deficiency of vitamin D. Vitamin D is a very important vitamin in our body, and there's a direct correlation between vitamin D deficiency and development of prostate cancer, lung cancer, breast cancer, colon cancer, and most recently, bladder cancer. So it is so important that you get your vitamin D checked. And once you get your vitamin D checked, make sure your provider fills the tank up first, because if you just start taking a maintenance dose, you're only going to maintain that low level. So the first thing you want to do is fill the tank up. And once you get the tank full, then you take your maintenance dose. And if it's recommended by your primary care, I would suggest that roughly around 4,000 international units of vitamin D is probably the best and the more appropriate dosage of vitamin D. The other interesting thing in this COVID environment we're living in, there's more and more compelling data to suggest that having your vitamin D corrected may provide some protection against COVID-19. So in summary, it is so important that we as an African-American community learn to eat healthy. We need to start at an early age. Instead of taking little Johnny or little Mary to those fast food joints to get that special burger with that special sauce and those fries, you need to take them home and give them a healthy meal to eat. And because this is the time that's most important in the prevention of prostate cancer. I appreciate the time. I'm happy to answer any question. Again, I apologize about the slides.